Welcome, everybody. My name is Susan Lautenbach. I'm one of the volunteers here at Epilepsy Awareness Day. And sorry, the last speaker went a little long, so we're going to make sure we get on time with Dr. Wechsler. It is a pleasure to introduce Dr. Wechsler. He's the owner of Consultants in Epilepsy and Neurology. And the reason why I have to read it is because I want to make sure I give him the respect that he deserves. A private practice specializing in epilepsy care in Boise, Idaho, and founder of the Idaho Comprehensive Epilepsy Center at St. Luke's Health System, which he opened in 2005. He is a clinical assistant professor in the Department of Neurology at the University of Washington and assistant professor at the Idaho College of Osteopathic Medicine. Dr. Wechsler received his medical degree from Finch University of Health Sciences, the Chicago Medical School, where he also received a PhD in neuroscience. He completed his residency in neurology at the Barrow Neurological Institute in 2003, and he is fellowship. He's actually sort of Californian because he was at Stanford University Hospital in 2005, finished his epilepsy fellowship there. He's board certified in epilepsy neurology and clinical neurophysiology, and it's my pleasure to introduce Dr. Wechsler.
Thank you, guys. So I will confess to you, I've got a bunch of slides on my laptop. Like I have a lot of slides on my laptop, but specifically for this week, I have some slides on my laptop because I'm developing a lecture on how to manage challenging epilepsy cases for the California Neurological Society, and I'm giving that lecture on Saturday down in San Diego. So I decided to kind of make a week of it. I'm super thrilled to be involved with Epilepsy Awareness Day. I gave a lecture on CBD last year. I don't know if any of you got to see that. My approach to these talks is that I want you all to leave here feeling like you've learned something and feeling like you've had your questions answered. Okay? So we can go through all of my slides or none of my slides. Or I can pull up specific slides based on specific questions. There's no hard and fast rules. I can give an epilepsy lecture in 5 minutes or 2 hours, depending on what's needed. All right. So what I was asked to speak about is challenging to treat epilepsy. And when I looked at all the other speakers that are lined up for today and tomorrow, I saw Dr. Sankar is going to be talking on the new epilepsy drugs. There are a number of people talking on how to pick patients for surgery for epilepsy. These are all also difficult to treat epilepsy stories. We have had some pretty exciting stuff come up in epilepsy medications, and we've got some pretty exciting stuff on the horizon with epilepsy medications. So I'm going to dive in, but I want you to feel free to interrupt me at any point with any question, and we'll make sure everyone's questions get answered. Deal?
Deal.
Okay. Does anyone have any questions before I even start?
Yes, I do.
Okay.
So my biggest concern is my daughter who has catamenial epilepsy.
Uh-huh.
In addition to, of course, regular epilepsy, and she has all types of seizures. She has focal, fatigue, grand mal, tonic-clonic, partial, you name it.
Mm-hmm.
But her seizures now primarily come with her menstrual cycle. And it's so frustrating because you don't know if it's going to come between day 1 and day 4. It's going to come also in the beginning or at the end.
Mm-hmm.
And we've tried numerous medications, no results. I tried the OCP, didn't help. Tried the Rivera, didn't help. And now she just recently started accepting CBD oil.
Mm-hmm. Mm-hmm.
And but and it's just like, I'm just wondering, like, they don't want to do any surgery for her cycle because it's not going to help, it's not going to make a difference because the hormones are the same. Or, this is new thing, we're looking at
Right.
she's only 24, so it's just like, how do I approach this? And
So,
then her underlying diagnosis is feeling nervous.
okay. So, for starters, it's all about getting on the right meds and the right doses and the right combinations, right? So our goal is always no seizures, no side effects. And what I tell my patients is we can get to no seizures and no side effects about 3/4 of the time. And if you end up being in the more challenging quarter, that's okay, because that's when I get to show you how smart I am. And we'll figure stuff out as best we can. And I'm going to keep trying until we either have a success or until you come back and say, Doc, stop it. Okay? And I've been telling people that for 17 years. And the one thing I can honestly say is I've never, ever, ever, ever met a patient where I'm like, okay, I'm out of ideas. Right? There's always more things to try. And it can be frustrating, right? You hear a lot of these statistics about the statistical chance of seizure freedom or seizure control with this or that drug or whatever. But the reality is that whatever happens to your daughter is 100% for your daughter, regardless of what the statistics say, right? And so it's always worth trying more, no matter how frustrating it gets. I had a patient years ago who I still see. She has frontal lobe epilepsy. And we literally tried on her every approved drug. She participated in a number of clinical trials with me. Then her friends were kind of egging her on to go get another opinion, and she went to the Mayo Clinic, which was fine. When she came back, I said, I just wish you had told me you were going. I would have made sure you got in with one of the good docs at Mayo Clinic. Or at least one of the more experienced ones. So she went up to Mayo Clinic. I had already had her in our epilepsy monitoring unit. I had already told her that I didn't think surgery was a good idea. I collaborate pretty closely with University of Washington and UCLA on those cases. I sent the data to those places. They did not think she was a good surgical candidate. She went to Mayo Clinic, spent a week there. They put electrodes inside her head. At the end of it, they said, yeah, you're not a surgical candidate. And then they sent her back to Idaho, and she came back to see me. And what really bothered me about that is I think she might have actually been a good candidate for the RNS device, which was still experimental at the time, but Mayo Clinic was one of the test sites, and they were inside her skull. And my question is, why not, at that point, offer her the study? And I think it was more about geography, distance, and cost than what was necessarily the best thing for the patient. She comes back to my clinic, and one of the drugs that I'd had her on for like 10 years as kind of the base drug for her was zonisamide. And because she was on zonisamide all those years, I never tried topiramate on her, because they're very similar drugs, very similar side effect profiles. So I'm flipping through this whole big chart when she gets back, and I see that we've never tried topiramate. And I said, you know what, this is kind of a shoot from the hip kind of deal. It's very similar drugs, but it's legitimately a drug you haven't ever tried. Let's bail on the zonisamide and put you on topiramate. Her seizures were super disabling. Like, it happened in the middle of the night. She'd go running out of the house, no matter what she was wearing. Even if she was wearing nothing, she'd run out into the street as part of her seizure. She's been seizure-free for 7 years. And it was literally the last thing we tried, right? But you know what? Every single person who gets their seizures controlled is going to get their seizures controlled with the very last thing they tried. Because once your seizures are controlled, you're not going to try anything else. So just keep trying, okay? That's number one. Don't get discouraged. Just keep trying. It might take years. It's worth to keep trying. With catamenial epilepsy in particular, we often will use, if her cycle's predictable, we can always add something around that time of the month for a week. And acetazolamide is used for that. I don't know if anyone's offered that to you. Okay. The benzodiazepines are often used for that, although they can be kind of sedating. Clobazam, however, which is a little bit less sedating than its cousins, has been used in catamenial epilepsy in Europe for years. So that's worth a try. And then there's the new stuff, right? You're just starting on the Epidiolex path. It turns out that Epidiolex plus clobazam might be a particularly good friendly combination. Okay? The company that makes Epidiolex has actually been publishing some stuff recently that even though you kind of have to worry about the potential for sedation when you use them in combination because the Epidiolex makes the clobazam stronger. It might be a particularly beneficial combination. In my expanded access program that I ran for CBD oil for Epidiolex in Idaho before it became approved, I had 39 patients. In that study, I allowed patients to go up as high as 25 milligrams per kilogram per day. And over the course of a couple of years that we ran it, every single family got to 25 milligrams per kilogram per day, right? So why? Partly because we're using it in very, very challenging epilepsy cases where statistically the chance of 100% seizure freedom are not very good, right? And so the families come back, well, maybe we can go a little bit higher. We've seen some improvement. We're not seeing any terrible side effects. Maybe we can go higher. Maybe we can go higher. And over time, everyone gravitates to the high dose. But high doses, sometimes doses higher than the FDA has approved, can be very, very beneficial. Okay? There were expanded access programs on the East Coast that were letting their subjects go as high as 50 milligrams per kilogram per day. Which, by the way, even the entry-level therapeutic dose of 10 milligrams per kilogram per day is way more CBD than you could ever afford to buy in a dispensary. Okay, so just remember that. It's very high doses. You have to check liver functions, all of that when you're on it. But it can be beneficial, and as long as you don't see adverse side effects, it's okay to go higher. Epileptologists that do a lot of medical management are going to have that experience, right? So I have some slides on how is it that an epilepsy drug is even born. And maybe we should start there, actually. I'm not going to do like Epilepsy 101 and all that for you guys, because I bet you all know a lot of the basics. I will put this slide up because in the interest of full disclosure, the red line is how I got to Boise, Idaho from where I grew up in Connecticut, and the places where I trained, and then the disclosures are in my gray box. So here's the deal. I'm in private practice, but I did a 2-year epilepsy fellowship at Stanford. People who do 2-year epilepsy fellowships generally end up doing research. I'm in Boise, Idaho. What research am I going to do? Well, I'm seeing all the toughest patients in Idaho. So I need access to things that they haven't tried yet, and doing research is a great way to have access to those things. So we got involved in clinical trials. And what I tell the companies is, I have academic training. I can get you data as good as any of the universities. But when you go to the university, you have to go through the contract and budget process, and it's 8 to 12 months before you can start. At my institution, I'm the clinician, the investigator, the chairman, the dean, the controller's office, and the IT department. And I can turn around a budget and contract in 2 weeks, and I can get you a bunch of patients while the attorneys at the university are still reading through your boilerplate template of your contract. So we've done that, and we've done very well with that. So I've worked with pretty much every company that has put anything out for epilepsy in the last 15 years. I helped develop the drugs. As I got further up in my career, I've helped to design some of the research studies. I've been an author on a lot of this stuff. And then when it comes out, I let them hire me to go teach other doctors how to use it, because I think it's irresponsible to bring new therapies to market and then kind of wash my hands of it and go, okay, now you guys figure out how to use it. Because there are so many things about the way the drugs are developed that no one ever tells you. And so let me start with that. That might be a really good way to start. I'm just going to put up a few things that you guys know. These terms are no longer used. Grand mal, petit mal, complex partial, simple partial, partial, psychic, dyscognitive, and secondary generalized tonic-clonic. All those terms were abandoned in 2017. Now we have focal with preserved awareness. Very descriptive. It's plain English. What the heck's simple partial? What the heck's complex partial? I would meet with doctors and they would call the seizures partial complex. And I would say, I don't think that's grammatically correct. There's nothing in the world that's partly complex. It's either complex or it's not. It's not a partial complex seizure. It's a complex partial seizure. No one could ever get it. We abandoned all of that. Focal with preserved awareness, focal with impaired awareness, focal progressing to bilateral tonic-clonic. Those are the focal epilepsies and focal seizure types. And then you have the generalized onset seizures. So tonic-clonic, so generalized tonic-clonic right out of the gate without any warning. Absence is still a term. Myoclonus, like juvenile myoclonic epilepsy, is still a term. And then the tonic and atonic seizures that often get lumped into drop seizures. Okay?
So a grand mal would be generalized tonic.
So that's the problem with grand mal. Think about this. Grand mal, petit mal. These are terms that were applied by the best medical minds of the 1800s in France, 100 years before anyone invented EEG. Okay? So when you had a genetic generalized epilepsy and you go into a grand mal first thing when you wake up in the morning, or you have developmental disabilities and you go into a grand mal out of the blue without any warning, or it starts like a small seizure and then it becomes a grand mal, focal to bilateral tonic-clonic, they all look the same in the eyes of the 1800s neurologists in France. It's big and it's bad, grand mal, right? And then we said, well, those are tonic-clonic, but how you get there is important. Does anyone know why it's important to know how a seizure even starts in the first place? Did anyone ever tell you that? So with focal, it can tell you what part of the brain it's starting in, but it also gives you information on what medication to use. Okay? So as we get into treatment, I'm just going to do this a little bit because I think it's important, but then we'll get to the how are drugs born. All right, so this is the history of all the anti-seizure medicines, starting with the bromide salts back in the 1800s when the French doctors were describing things. And this now pretty much constitutes what we call the first generation of anti-seizure medicine. These slides are all going to be on the website, by the way, if they aren't already. So everything from 1857 all the way to 1983, when the current version of Depakote, the divalproex version of Depakote came out, that's the first generation of anti-seizure medicines. And most of those were dumb luck discoveries. Oh, look, it helps. From 83 to 90, not much happened. In the early 90s, and this was like the fruit of the labor of the decade of the brain, if you guys ever remember that was being tossed around. All the drugs in the middle column are the second generation of anti-seizure medicines. And they're basically all born out of a drug development program that was funded by the NIH. And the concept was basically, we're going to take a bunch of molecules, we're going to throw them in a bunch of mice with epilepsy, and we're going to see what sticks. And so Felbitol was the first. It had a little bit of an issue, which put all doctors into a panic. Like the entire neurology world suffers from collective post-traumatic stress disorder because of felbamate, which is why you see that a lot of doctors are slow to prescribe the new drugs when they first come out. Because everyone's sitting on their hands going, I'm not prescribing it until there's 100,000 people on it worldwide. 100,000 is the magic number. And part of the reason 100,000 is the magic number is that's how many people got to be on Felbitol before the Felbitol issues were identified. And by the way, Felbitol worked so well that the FDA never pulled it off the market. And it's still available today. It just has a warning, and you have to do a bunch of paperwork, and your doctor has to do a bunch of paperwork. It's like, the reason a lot of doctors don't prescribe felbamate, honestly, is you have to sit there for a half hour and go through all this paperwork, and you can be like, do you understand that if I put you on this drug, it could kill you? Do you understand that we have to check all this blood work all the time? Do you understand that checking the blood work doesn't guarantee that you won't die from taking this drug? It's scary, right? And there's so many other things to choose from. But in some people, Felbutol has been a lifesaver, right? All right, so Felbutol was the beginning of the second generation of drugs. And then, as we moved into, my buddy Barry Goodall and I at University of Wisconsin were the first, I think, to start kicking around the phrase third generation of anti-seizure medicines. And everyone kind of looked at us askance for saying that. But everything in the column on the far right there is the newer drugs. And what distinguishes, in my opinion, that third generation of drugs is that many of these drugs come out of rational, strategic drug development. Like when ASI said, scientists, go into the basement laboratory and don't come out until you have an AMPA receptor blocker for us that doesn't make people sleepy. That's how Vicompa was. They didn't really lock them in the basement, but you get the idea. So many of these drugs in the third column are rationally developed drugs, okay? So then when we pick drugs, we have to think about what else the patient has, right? So if they've got migraine, or then I might put them on something that helps both. If they've had kidney stones with acetazolamide, I'm not going to put them on Topamax or Zonograd because those things are going to potentially cause kidney stones too. So we think about all these different things, right? So we think about, and this is what I was going to get to. So we have drugs that are really good for treating focal epilepsy, but some of these drugs can make generalized seizure types worse. Okay? So you take someone who has Dravet syndrome and you put them on a sodium channel drug, you're going to make them worse. How many people here have someone with Dravet in their family? Anybody? See, Susan, I told you, no one with Dravet ever comes to listen to me. I met with a family. They actually bid on a thing at our Epilepsy Foundation, and I took them and their friends on a wine tasting tour of Idaho wineries. And they were telling me their daughter's story and how mad they were, their pediatric neurologist, who had their daughter on lamotrigine for a couple of years. And that's around the time that we figured out that lamotrigine actually makes kids with Dravet worse. So they were pissed because their doctor had them on this drug that was making their daughter worse for like 2 years. Can you imagine? So, sodium channel drugs.
Is that only with Dravet syndrome that makes your child worse?
So with Dravet syndrome, there's that sodium channel mutation,
Okay.
right? In about 80% of the cases, it's confirmed with genetic testing. And any of the quote-unquote sodium channel drugs, so phenytoin, carbamazepine, oxcarbazepine, eslicarbazepine, lamotrigine, can potentially make Dravet worse. Okay? Maybe lacosamide. We haven't been brave enough to try it because we know that sodium channel drugs we don't want to put Dravet kids on. But it goes beyond that. Right? So if you have absence epilepsy, plain old run-of-the-mill textbook childhood absence epilepsy that you've got an 80% chance of outgrowing by adolescence, okay? But some well-meaning doc decides to put you on Neurontin or Lyrica for your pain. You can take that kid with absence and put him into absence status epilepticus, give him a seizure that just doesn't stop with those drugs. Tigabine is another one. It's not one we use very much because it's 3 times a day and very sedating. But that's another one that was famous for making kids with absence worse. So when we know that something works for focal epilepsy, but is going to make generalized epilepsy worse, we call it a narrow spectrum drug. If we know it's generalized epilepsy, or if we strongly suspect it's generalized epilepsy, or if we have no clue what type of epilepsy we're dealing with, then it makes sense to stick with the things that are going to be most safe, most broad spectrum, because we don't want to make anyone worse. Right? So when I was in my training, we had the 5 big broad spectrum drugs, which is Depakote's the granddaddy of them all, broad spectrum drug. And then we had lamotrigine, levetiracetam, topiramate, zonisamide. Those are the big five, and felviprol. Those are the big 5 to 6. Today, we now know that perampanel is broad spectrum, but I'll let you in on a little secret that even the doctors don't think about, and even the pharmaceutical companies don't think about. Any drug that has ever been approved for Lennox-Gastaut syndrome is by definition a broad spectrum drug. Because Lennox-Gastaut is not a specific diagnosis, it's a catch-all for a bunch of different conditions. And within that patient pool, you have focal seizures, generalized seizures, seizures of every type, drop seizures. I always tell people, tell me a seizure type that doesn't happen in Lennox-Gastaut. There ain't one. Right? Now, in an individual patient, you might not have every seizure type. But when you pull a couple of hundred patients with Lennox-Gastaut as their diagnosis together, in that pool, you're going to have every seizure type represented. And if that's the population that you're going to study, and yeah, you're counting their drop seizures or you're counting their tonic-clonic seizures, but you're also counting everything else that happens, right? I mean, you can't get a urinary tract infection while you're in a research study without that data getting captured somewhere. So when we do these studies in these groups, we know when that drug got approved for Lennox-Gastaut, it did not make any seizure type worse. There is no seizure type that has ever been made worse by clobazam, by rufinamide, by Epidiolex, by Fintepla, which is kind of the new kid on the thing. So when something gets approved in Lennox-Gastaut, dollars to donuts, it's going to be a broad spectrum drug, and it's going to be safe to use, even if your doctor's kind of going off label because your particular diagnosis label doesn't match what's on the label of the drug. It's okay. All of a sudden now we're very interested in genetic diagnoses, right? So we want to do the genetic testing to prove that it's Dravet, or is it CDKL5, or there are all these different genetic things that are coming up. But you know what? Every one of those genetic conditions, up until that gene was discovered, got lumped into the category of Lennox-Gastaut. Because what do you need to get a Lennox-Gastaut diagnosis? You need multiple seizure types. The caregivers that bring patients into my office, often, who are not family members, will typically say, when I ask them, what kind of seizures does this patient have? They'll say, oh, both, doc. They have big ones and little ones. I hear that a lot, right? Okay, multiple seizure types, check. Big ones and little ones. Developmental disability. That one's pretty easy to spot, just walking in the room in most cases. And then a particular pattern on the EEG that you may or may not catch, and that may or may not get outgrown as you get older. So if you have one of these syndromic conditions that kind of looks Lennox-Gastaut-ish, and you get to age 20, and they do an EEG and there's no slow spike wave, does that mean you don't have Lennox-Gastaut anymore? No. Normal EEG or inconclusive EEG is always, always, always completely useless information. What I tell my patients is swap out the word EEG with the word movie camera. Okay? If I hand you a movie camera to make a movie for 30 minutes or an hour on a beautiful sunny day in Southern California, can I use that movie to prove that it will never rain again? Of course not. And if I do an EEG on what is a beautiful sunny day in your brain and it comes out normal, does that mean you don't have epilepsy anymore? No, it just means nothing happened during that hour. Okay? So we got to know what we're treating, and if we're not sure what we're treating, we're best off sticking to the broad spectrum drugs. Head-to-head trials, there aren't any. Very few. Because you know what? You're a drug company. You're going to spend somewhere between $500 million and $1.5 billion to get your drug onto the U.S. market. before you've ever sold a single pill. And you don't turn a profit until your sales exceed what it cost you to develop that drug. Okay? Now, you going to go head-to-head with a competitor to see who wins? If you don't have to? No. In Europe, that's how drugs get approved. Everyone goes head-to-head with like carbamazepine for the most part. And all they have to show is that they're not inferior to carbamazepine. In the United States, the FDA wants to approve drugs that are superior to something else, and no one's brave enough to even go up against carbamazepine in the United States because they would have to demonstrate superiority. And we've only ever had one drug that convincingly has come out to be superior looking on paper. And so you're not going to take that risk. So head-to-head studies are few and far between. What we do in the United States is we compare to placebo, because it's easy to prove that you're superior to placebo and satisfy the FDA. Right? The drug studies are not designed for you or your family members in mind. The drug studies are designed for the FDA, because the FDA gets to decide whether or not that drug goes to market, whether or not you recoup your investment. So that's what I really want to kind of touch on with you guys, is how do we design studies? All right. So like I said, it can take 10 years for a molecule to go from the basic science lab into the clinic. During that 10 years, a company will typically spend somewhere between $500 million and $1.5 billion to develop that drug, and they're going to focus on the indications that are most easy to secure. Right? You got a new drug. Are you going to start by looking at CDKL5? You're not going to make a lot of money if that's where you start. So where's the best place to start? Focal onset seizures. They're prevalent. There's lots of adults with them. We don't want to start experimenting with children. So we start by testing in adults with focal onset epilepsy. That's where most of the drugs start their journey. And then later on, once they've got the approval, once the company can make a little bit of money off of those prescriptions, then they say, all right, now we can afford to do a study to see if it works in primary generalized tonic-clonic, or whether it works in Lennox-Gastaut or Dravet or whatever. But those indications usually come later. There's one company that kind of made it fashionable in the epilepsy space to go directly for rare disease. And that's Lundbeck when they came out with clobazam, Onfi. Right? Clobazam's not a new molecule. Clobazam's been available in Europe since 1974. It became available in the United States in 2008. Why? Because when it was first developed, it was meant to be a less sedating benzo for people with anxiety. And then once it got onto the market in Europe, people started to figure out that it actually had a pretty good role in epilepsy. In Europe, they've been using clobazam the way we use clonazepam. Okay? How many of you have ever had either you or a family member put on clonazepam? Anybody? Yeah. The Europeans don't use the clonazepam. It's similarly long-acting, but it's a lot more sedating, and there's more potential for habituation, where it stops working and then you need to go to a higher dose. So now that Onfi has gone generic, now everyone's getting comfy with, all right, let's take a look at clobazam. And I think in another 5 or 10 years, we're going to see both the neurology and the world and the psychiatry world jump onto the clobazam bandwagon, and then clonazepam, Klonopin will be a distant memory. But that's kind of how it all comes to be. So why would a company decide to just go for Lennox-Gastaut with clobazam? Because the FDA created an orphan drug pathway. And the FDA said, if you want to develop a drug for a rare disease where there isn't much in the way of treatment options yet, we are going to set the bar low. You don't have to do 3 phase 3 trials at, $200 million a pop or whatever it is. You can do one well-designed study in that rare disease, and we will approve you for that rare disease. We're going to lower that bar to make it easier for the companies to be willing to afford to develop those treatments. So with those changes, what have we gotten? We got Onfi that way, we got Epidiolex that way, we got Banzel that way, we got Fintepla that way. All these drugs that have come out, that have come out in the last few years that are specific to these various diseases, that's how they came about. Because the FDA made it financially practical for the companies to go for it, right? I mean, look, if you're going to spend $1.5 billion, and if you've got 10,000 employees that want to raise every year, and benefits, and a steady paycheck, that money's got to come from somewhere. And if you're not selling pills, where's the money going to come from? So what they do is they develop a drug, they launch it, and they take a big chunk of that profit and use it to fund the next thing, right? And that's how it gets going. All right, so they're definitely going to pick a dose range that's going to set them up for success. They don't want to test a really low dose that looks ineffective and risk the FDA saying your drug isn't good enough. They don't want to test a dose so high that it makes people feel icky and the FDA says your drug's not safe. So they kind of, all right, leucosamide's a great example. Vimpat. I was the lead author on the Vimpat paper for monotherapy, right? 30 countries, 80 test sites, and it was my baby. And I got to review all of the data and sign off on it before it was submitted to the FDA. The Vimpat was already at that point approved as an add-on treatment for epilepsy. Now we were showing that it worked as a standalone. It was approved as an add-on from 200 up to 400 milligrams. Those were the doses that the company submitted to the FDA for approval. And that's what they got. Okay. Turns out about half the patients in those early studies were on other sodium channel drugs in the background. So if they went higher than 400, they got a lot of dizziness. They did go higher than 400, but the incidence of dizziness was so high that they decided not to seek approval for the 600 milligram dose. So they only submitted the data on the 400 milligram dose. Okay? Now, when we went to the monotherapy study, we were allowed to go as high as 800 milligrams per day with glucosamide. Turns out, if you're under like 250, 300 pounds, you're not going to tolerate more than about 600 milligrams of glucosamide. So 600 is kind of my upper limit now. But what's the maximum FDA approved dose? It's still 400 milligrams, right? And if I put you on now in the open label extension to that monotherapy study, we followed patients out for 2 years. When they were on Vimpat as a standalone drug for focal epilepsy, the average dose they landed on over the span of 2 years was 550 milligrams per day. That was the average, okay? But if I go above 400, my patients worry that I'm trying to poison them. The insurance company's telling me that I'm writing the drug inappropriately. The FDA says that I'm going above the approved dose. The company lawyers, if I'm doing a talk about Vimpat, I'm not allowed to say that I sometimes go higher than 400, because that's off-label. Okay? But where did the label come from in the first place? It's like this weird, bizarro, circular reasoning way of getting these drugs onto the market. And if you were working with someone who actually knows how the drugs get there and how they work, you might find that you do a little bit better, right? So Epidiolex, maximum approved, is 20 per kilo per day. Unless you have tuberous sclerosis, then you can go to 25. Why? Is there something special about tuberous sclerosis that lets you go to a higher dose? Not really. But that's what we do. Yeah.
Can I just ask you a question? So what makes Epidiolex different than CBD?
Purity.
Okay.
Lack of contaminants. And
obviously
highly
higher
concentrated.
dose. Okay.
Highly concentrated. So I
asked that only because I sat and taught a couple years ago on another epilepsy
Yeah.
prevention thing, and the doctors are saying, well, there's no proof that CBD really works, yada, 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 but then on the one hand, the pharmaceutical one, that one's great, but, so it's like, well,
Right, so,
CBD
all right, so
really
here's,
work or not?
right, so in a nutshell, with
Yeah.
the CBD thing, number one, when you're buying from a dispensary or whatever, or the gas station, because now it's available at the gas stations in Idaho too, you don't know that what's in the bottle is what's on the label. Supplements are not regulated in the United States. Okay? So in Colorado, where they were early adopters of cannabis in the treatment of epilepsy, there were case reports of people buying pure CBD oil from the dispensary and their kid landing in the emergency room with THC toxicity, because there was way more THC in what they were buying than what was on the label. Other times, the FDA has sent warning letters. So the FDA doesn't touch supplements, right? It's considered a food. That's why if you buy something from a dispensary, it never says the recommended dose. It says serving, because it's a food product, not a medicine. As soon as you make a medical claim, you come under the purview of the FDA. So there are companies that have made medical claims about their CBD products in the dispensaries. And when the FDA catches wind of this, bam, they come in, they do an inspection. And they say, show us the science to back up what you're claiming. And they don't have it. And then they analyze the product. And what they found was 30 to 40% of the time, the bottle of CBD from the dispensary had 0 CBD in it. Okay? The number of milligrams that you need, if you think about the average adult, according to the FDA, because, in the United States, when you're a child, we calculate your dose based on your weight, milligrams per kilogram body weight. But then when we turn 18, we all weigh the same. Because then you just transition to adult dosing, and that dosing's pretty much predicated on the assumption that we all average out to about 75 kilos, about 150 pounds. What, you weigh more than 150? Or you know someone who weighs more than 150? I do. So that's how, and what do we do when someone is morbidly obese? Well, you can't be in the study, because that medical condition is going to interfere with our data. So if your body mass index is higher than 35, you can't be in most clinical trials. And then what do they say? If you have heart disease, if you have liver disease, if you have kidney disease, you can't be in our study. And then the drug comes out, and what do they say? We don't know how this is going to affect people with heart disease, liver disease, or kidney disease, so we don't recommend using it in those patients. But what's driving it all is trying to get the work done, to get the FDA on board, to get the approval so you can sell it. And the dispensary companies want to sidestep all of that, because really what's going on is that those companies want to get recreational cannabis everywhere, and the medical use is a stepping stone. And they're relying on the moms of kids with severe epilepsy to be their advocates, their sales force, you see these moms that are wheeling the kids into the Capitol building to try and get some bill passed to allow this or that. And they're being used as pawns, right? I have a friend who got a phone call from the Stanley Brothers, right? So the Stanley Brothers made the original Charlotte's Web in Colorado. We'd like you to participate in an advisory board on how to get our product onto the market more widely. And he says, oh, that's great. And it's going to do some science to show that it works. No, we're pretty convinced it already works. We just want to figure out how to get it recognized as an official supplement. He says, well, there's no such thing as an official supplement. Yeah, but still, that's kind of the advice that we're seeking. Well, how are you paying for this initiative? Well, that's being funded by one of the Stanley Brothers' other businesses. Only other business they're in is recreational marijuana. Okay? In fact, think about this. Imagine for a moment that you are running a dispensary, or you're a grower growing stuff for a dispensary. Do you want your product to be recognized as an official treatment for epilepsy? Do you? No, you do not. Because then you've got the FDA on your butt, supervising everything that you do. Right? Now it's a drug. Now you need a prescription to get it. You gonna make a lot of money with it? Not so much. So you keep it low key, you get the families involved, you get people going into the Capitol building to protest and request and ask and da-da-da-da-da, and you get your medical approval, and then a year or two later you go for recreational approval in the same state. And that's what it's all about. And it has nothing to do with trying to make people better. Right? So when a pharmaceutical company comes along and they develop an ultra-purified, high-concentration, low-volume oil, to get one dose of Epidiolex at a dispensary, you'd often be going through an entire bottle from the dispensary to get the same amount of CBD out of it. And that bottle is going to run you $200, $250, right? Do you know how Greenwich, who now got bought out by Jazz, that's why you see the big Jazz sign at the end, do you know how they picked the price point for Epidiolex? When they decided, okay, we've got the approval, we're going to sell it, how do we price it? Let's see what they're charging in the dispensaries in number of dollars or cents per milligram of CBD. And that's what we're going to charge. So if you go to buy your Epidiolex and you pay cash out of pocket without getting insurance involved at all, the price that you're paying for that dose, for that number of milligrams, is the exact price that you'd be paying in a dispensary for the same number of milligrams. But whereas with Epidiolex, you're getting that dose in 1 or 2 teaspoons, at the dispensary, you're getting that dose in 1 or 2 bottles. And if you're getting the Epidiolex, it's FDA approved, which means insurance will pay for it. If you're going to the dispensary, ain't no one paying for it but you.
And you're paying taxes, which you're paying taxes and all the city fees, and that actually makes it more expensive.
Exactly.
But I remember also that wasn't something that you could really get your doctor to prescribe. But is it more now? Is it kind of
Well, with Epidiolex, it's pretty widely accepted now in the neurology space. You know, a lot of this varies by state, right? Like, as soon as Epidiolex got approved in Idaho, I mean, everybody and their cousin wanted to try it for everything, right? How exciting. You've got CBD oil in Idaho. In California, I was having lunch with a doctor, a pediatric neurologist outside of Sacramento, and the company had paid me to fly in and have lunch with him, and then I was going to have dinner with some other doctors. And I was sharing the Idaho experience, and he said, you know, here in California, it's different. Here in California, everybody's already tried it from the dispensary, and a lot of times it just didn't work because the dose was too low. And so California doctors are in the position of having to try to convince their patients to try it, because the patients are saying, yeah, I tried CBD, it didn't work. Well, where did you try it from? Was it the correct dose? Okay? So you need to think about this stuff because it's not enough to just go off of what's on the label. And it's not enough to just go off the paper that gets published that supports the science that leads to the label. You really have to have the know-how to dig down into the history of the development of that drug and look at all the papers in unison to have a really good understanding of what's really going on with dosing and interactions and all that other stuff. And if all you're going from look, there's literature out there which shows that a vast majority of the time, doctors don't have time to read scientific papers. Most of the time, they just read the abstract, which is the paragraph summary at the beginning. Sometimes they just read the title. Okay? If that's who you're seeing as your doc, how are they going to learn all the nuances of these drugs without diving into the full paper and the method section and all of that? And not just that study, but the studies that led to that study, which led to the label. Well, let's just put blinders on and follow the label. It's what FDA says is okay. And I do it too. When I get outside of the epilepsy space, I tell my patients all the time, if you have epilepsy, there's no one else you want to see in the state of Idaho. If you have anything other than epilepsy, God help you if I'm your doctor. Because I'm not smarter than anyone else. I've just chosen to be more focused. And so I know the epilepsy stuff inside and out. But at the expense of, I'm not staying up on all the new MS drugs and all the Alzheimer's. I don't see that. I send that to general neurology. All I do is epilepsy. Okay? So it's important if you're picking a doc or picking a new doc to ask some of those probing questions about how do you get new information about drugs when they're released. And to be honest with you, if it were me and the doc said, well, you know, I look at the package insert and I see what the FDA said, and that's not enough. Epidiolex says on the label, half in the morning, half at night. Clobazam, Onfi, says on the label, half in the morning, half at night. That's how those studies were designed. That's how that got onto the label. What's the half-life of clobazam? 40-ish hours. What's the half-life of Epidiolex? Also 40-ish hours. They are legit once-a-day drugs. Why were the studies designed with half in the morning, half at night? They were designed that way because they didn't want to make anyone too sleepy because that was going to scare the FDA. So we'll divide it up, half in the morning, half at night, to keep the side effects down to a minimum. But if you understand that the half-life is 40 hours, perampanel has a half-life of 105 hours by combo. You'd never do it, but in theory, that's a drug you could take every other day, every third day, and probably be okay. Right? We do it once a day. But you don't know that. So you get your prescription, it says give half the Epidiolex in the morning, half at night. Give half the clobazam in the morning, half the clobazam at night. And what are you going to get? You're going to get a patient who is groggy during the day and not sleeping well at night. I tend to put all my drowsy drugs in the evening time. Not right when you're getting into bed, because I don't want you to be hungover the next morning when you wake up from all the meds right before bedtime. But I say right after dinner. Take your meds with dinner or right after dinner, unless the medicine itself says don't take it with food. But I do it that way so that it kicks in about bedtime, because most of these drugs are going to take a couple, 2, 3, 4 hours to get into your brain. So you get the most of the sleepiness kicking in at a bedtime, and you get most of the side effects wearing off before you wake up the next morning. Doesn't that just make more sense? But it's not on the label. And the reason it's not on the label is because it wasn't in the study, and the reason it wasn't in the study is because the study was designed to make the FDA happy. It wasn't designed to make the patients function the best. So a lot of times, there's 1 or 2 drugs that have doses higher, that are approved, that are higher than anything I would ever prescribe. Topamax being one of them. It's approved up to 800, and that's way too high. I have a buddy who prescribes that dose for migraine. And I always ask him, Larry, are you treating their migraine, or are you trashing their memory so bad that they can't remember that they had it? So that's one of the rare scenarios where we have a drug that's approved at a higher dose than what we actually use in the real world. But for most of our drugs, we use doses substantially, in some cases substantially higher. Xcopri is another new drug, just in the last couple of years. I think it's a game changer. 1 out of 5 people became seizure-free in those drugs. Right? So far, it's only approved for focal onset seizures. It's being studied for generalized tonic-clonic. I don't think they're ever going to study it for, say, Lennox-Gastaut or Dravet, because they've got other stuff in that they want to explore in that direction. But it's a fantastic drug. And it's approved like 100 to 400 or whatever. Most people are supposed to end up between 200 and 400. I've had patients that have become seizure-free on just 50 or 100 per day. Ex-cochlear. So every one of my challenging epilepsy patients, they're getting a test of ex-cochlear. Anyone who's on the launch pad to go to Seattle or Los Angeles for brain surgery, I tell them they have to try ex-cochlear first, because 1 out of 5 won't have to get surgery. So you got to know the nuances of these drugs and how to use them, and you got to be working with a doc who can answer those questions for you. And you know what? Yes, there's a neurology shortage in the United States, but you can still find someone else, especially if you're living around here. There's more epileptologists here than in the entire Northwest. So shop around, but find someone who can answer those questions for you. Yeah?
So you mentioned that clinical trial designs are not geared towards patients. Do you see that changing over the next 5 years, and what's driving that change?
No.
What could drive that change?
Money, free money. I mean, at a fundamental level, it starts with, we've got something, we think it might work. Let's do some studies to convince ourselves that it might work. And at some point, you got to try it in patients. And once you start trying it in patients, the brain goes to, all right, this might work. How do we get the FDA to approve it? And then everything gets designed to get the product through the FDA as quickly as possible. Because, by the way, the patent life doesn't start necessarily with the approval. It has to do with when the molecule was first invented. So every year that you spend in research without selling pills is a year of lost revenue.
How long is the patent life?
Varies, but typically about 10 years. They get 10 years to try and recoup all their investment on that drug. And it's kind of like with the movies, right? You see these big blockbusters that come out. It was $500 million to make this movie or whatever, right? If they don't sell enough tickets to make up their investment, is there a sequel? You only get the sequel if they sold enough tickets to make a profit after they recovered their investment.
Last question to the back of the room. Thank you, Dr. Wechsler.
Hi, so
That's you.
Yeah, go for it.
So when you try new medication and you start having, instead of a decrease of seizures, you start having like a normal increase of seizure or abnormal seizures, how long should you stay on it before you even give it a chance?
You know, that's a tough question. So she's asking, like, you start something new and you actually see your seizures getting worse rather than better. Okay? And that's a complicated question because there are a few nuances that we don't know. Is something else being reduced while the new drug is going up? Or is it just that drug? Then the next question is there a drug interaction? So even though you're swallowing the same dose, your blood level for one of your old drugs might be lower if the new drug is knocking the old drug down. If it's accelerating how the liver processes that drug.
Because usually, like within 24 hours, you will notice a difference. And I refer to them as mutated seizures because it will be like, she'll go into like a complex partial type seizure, and then she'll go into a generalized seizure, and then she'll start fully convulsing. And she'll start all the seizures. It's like multiple seizures in one seizure.
It would be big.
And she'll all be and usually that within,
No, small.
and it's within 24 hours. And when she was 16, one of her medications,
That's
they
terrible.
upped it, and she ended up developing type 1 diabetes. She was really lethargic.
I don't like that.
Well, one of the doctors told me that they noticed other people that
That might have been
developed-
Depakote can do that.
it was actually, I think it was Topamax.
Okay.
No, it was Zonogram.
Okay.
I think it was Zonogram. I'm trying to think because I know that the doctor, he had to change because he kept saying, no, it's not the medication. And he finally figured out every time she took it, everything would change in her system. You know, 'cause they
So
would go for-
what I will tell my patients is, whenever we try something new, I want you to try really, really hard to give it 2 weeks for it to settle out in your system.
We did.
Before we bail on it. And unless the wheels are coming off the bus, then we have to figure something out. And if we're running into the same issue with multiple drugs, think about this. The drugs all work in very, very different ways, right? Just because I had an allergic reaction to an apple doesn't mean I can't eat bananas, right? And so if you're seeing the same problem with apples and with bananas and with oranges and with artichokes, there might be more to the story, and that's a good time to maybe do some video EEG and figure out what's really going on, because you might be barking up the wrong tree a little bit.
We did all that too.
Yeah. Do it again.
We did that.
Never give up.
We did several EEGs,
Yeah.
in the hospital and everything. We did a VNS.
Move to Idaho.
It's empty now. Right? Thank you, Dr.
All right.
Wechsler.
Thank you guys for having me.